All right, everyone. Welcome, welcome. So excited to have you here. It's officially 5:30 p.m. Central Time. My name is Dr. Jennifer Bonner. I am a certified nurse midwife with 4 years, almost five of experience as an APRN and over 15 as a registered nurse. So currently here at Archer Review, I serve as the tutor team lead. So a lot of what I do is one-on-one tutoring, mostly with nursing students. I do a lot of webinars, small group tutoring, that type of thing. But today I'm so excited to be bringing you this webinar on the reproductive system, GU for the APRN. So we're going to be talking about all types of assessment components from the health history to practical advice. So who is excited to be here? Let me know. Raise your hand. Show me in the chat who is excited to be here. Anybody brand new to one of our webinars? Okay, I'm seeing several hands up. That's great. So excited. All right. So, just a couple housekeeping things before we get started. So, one of the things, if you have a question that you need answered, I want you to go ahead, put that in the Q&A, the question and answer box. So that's a way that I'll be able to see your questions. I'll be able to get them answered pretty quickly. If you just have a general comment, let's say I said 2 + 2 is 4, and you're like, yes, that's right. That's a good place to put that into the chat. I will make sure, let's make sure that everybody is able to see the chat here. Let me get that open for you here in just a moment. Chat. There we go. And you should be able to see that now. And then we'll go ahead and make sure that is working. So let me know who is excited to be here. Who is excited to be here? Let me know in the chat. Awesome. All right, welcome. So, just a few things before we get going. I just need to share some disclosures with you. So, we are accredited as a provider of the Nursing Continuing Profession Development by the American Nurses Credentialing Center's Commission on Accreditation. So, we are so excited to be offering this for you. This course is going to be offered for one contact hour, and you need to attend at least 80% of the time that we are here. We don't have any relevant financial relationships, any position or content that's being shared, and we don't have any commercial interest that's being provided, financial or in-kind support for our educational activity today. So let's take a look at our objectives. What is it that I'm hoping that you will get out of today? Well, there's a couple different things that I'm hoping you will get out of our time today. So the first one is I'm hoping you're going to be able to demonstrate taking that comprehensive health history, identifying those normals versus abnormals. I'm hoping you're going to be able to differentiate that pathophysiology, those key clinical presentations, that first line evidence-based information for those common disorders we're going to go through, and also to develop that patient education and follow-up recommendations. We're going to incorporate the preventative screening guidelines that we'll go through and then talk about our different populations. All right. So without further ado, if you've ever joined one of our webinars, you know we're going to use Slido. Now, Slido is a great tool. You can go ahead, scan your QR code there by using your smart device, or you can just log in at slido.com, enter in the code all caps GU exam, and that should get you right where you need to be. So here we go with our first question. I want you to tell me whoops, sorry about that. How comfortable do you feel about GU? How do you feel about it? Are you one of those like totally crying boo emoji? Or are you very much an excited, I love this, Jennifer, get out the way. I could totally teach this for you. Let me know. Okay, seeing some kind of right down the middle. Nobody's really excited for it, but nobody's totally hating it either, and that's okay. So the other thing is I'd like to know if you can let me know in the chat who is joining me. Are you in nursing school? Are you in APRN school? Have you graduated, getting ready to take your exam? Are you an APRN already? Let me know who is joining me today. APRN school taking comps. Awesome. Christina, welcome. So glad to have you. Good luck. We are here for you. If you have missed any of our other webinars, just a little information, they're available on our Facebook page and our YouTube channel that you can go back and visit those. Very good. Awesome. So a little bit more background about me. So I graduated with my BSN, jumped right into a new stroke unit, new stroke ICU that was new to the area that I was moving to. So I jumped right into there, did some time in the ICU of the neuro unit as well. And then I jumped into what I lovingly refer to as the butts and guts of the hospital because I was going back to APRN school. I was going to become a family nurse practitioner. And so I graduated, unexpectedly became a mama, which I was delighted about. And I realized during that time that I really love women's health. That's one of my very favorite things to do. And so I went back to school to become a certified nurse midwife, finished my doctorate shortly thereafter, and then practiced in a clinic for quite some time before I transitioned into education. So I've been with Archer for about 2 years now, and I absolutely love what I do. I love working side by side with students, breaking down these difficult concepts and helping you understand these just a little bit more. All right, well, let's go ahead and jump into the nitty gritty of what we are here to talk about. So, we know that a thorough genitourinary history is going to help us identify a lot of different things, right? It's going to help us identify those potential conditions. Early recognition of those things can be detrimental. It can be very helpful for our client. We're going to guide examinations with this, and it's also going to help us with our decision making skills. So, we're going to look at a couple of the components that make up a good history. But before we get started, let me know, what do you find as a key component in your health history? What is it that you're looking for? Let me know in the chat. What kinds of things are you looking for in a good health history? What are we looking for in a good health history? Okay, so we are looking for lots of different things, right? We're looking for sexual history. Yes, you got it. We are looking for any other significant medical history. We're wanting to know if they have any issues with using the bathroom, any problems with incontinence, last menstrual period, their G's and P's. Yes, absolutely. Very good. So when we talk about the health history, it's important that we understand those components of that. So we want to start off by finding out what it is that's actually bringing our client to us today. So what's going on in your life that you're like, you know what? I need to go be seen. Something is happening. I need to go be seen. Many times when we walk in, we already have our little intake form that's been done by maybe the LPN or the RN or maybe our medical assistant. They've already filled out the medical intake form. Maybe we already know why they're there. But if we can ask and kind of get it in their words, it's really important because a lot of times, I don't know if you guys have noticed, but sometimes when we go in to see our clients, sometimes they share more information with us than they share with the person that took their intake. And so they're a lot more forthcoming with information because they really want help, especially when there's an issue going on. So it's really important that we get it in their words, figure out what is it that's going on that is bothering them that they felt like they needed to be seen. So we want to start by gathering some details on our patient, right? We want to know, obviously, how old they are. We want to know, have they ever been pregnant before, depending on if it's male or female. We also want to know what age of menarche. So obviously, in that case, we're thinking females. The menstrual cycle, how regular is it? How long does it last? When did it start? Has it always been regular? Is it painful? Things like that. And then we also want to know any other abnormalities. Is there pain with it? Do they have any urinary concerns? That type of thing. Now, in my practice, I was very much focused on infertility. That was one of my specialties. I absolutely loved it. My physician was, my attending was not so involved in it that she's like, Jennifer, this is your love. I'm going to let you just take that on. And I absolutely loved it. I love sitting down with clients, walking them through that process. And so a lot of times when they came to see me, they may have fertility concerns and they're trying to figure out, I want to start a family, but this is not happening. So let's get down to the bottom of it. And if you've ever been there, I'm very sorry. I can empathize with you, but it's very personal. Right. So we want to make sure that they feel seen, they feel heard, and we are able to have that conversation with them. So, other things that we want to know that would also be important to consider is their obstetric history, right? We want to know how many times have they been pregnant. Remember, their gravida includes if they are currently pregnant. We want to make sure that we include that in their number. How many children have they had? How many were term? How many were preterm? Have they had any abortions or miscarriages? Now, remember, so let me write this out for you. Take a moment. Sometimes this can be a little bit difficult to understand, but when we talk about GTPAL, this is how we kind of communicate to other people the obstetric history of our client. So their G's are how many times have they been pregnant. It doesn't matter if they carried to term or it was just a couple weeks. If they have been pregnant on occasion, that each occasion, I apologize, each occasion is considered in their G. Their T is for term. So we know that term gestation is considered 37 weeks, not 36 and 6 days, 37 weeks. So anything 37 weeks and over is considered in the T. P is considered preterm. So preterm is anywhere from 20 weeks all the way up to 36 weeks and 6 days. It doesn't matter if they were born stillborn or if they are just a vigorous baby. If they were born in that amount of time, it's considered a P for preterm. Now, abortions, a lot of times when we hear the word abortion, it has a connotation, right? We have some type of a mental picture of what that looks like. But in this context, this is any birth that occurred before 20 weeks. That is going to fall in that A column, and L is living. So living can change from year to year. I had women that would come in one year. We had someone that we had been working with, and she actually lost one of her children almost a year old. And so the next year when she came in, her L number was a little bit lower than it had been the year before. So GTPAL is really important to understand. It's also very helpful when we are trying to figure out what it is that's going on with our client. It tells us a lot of information. We also want to know about their sexual history. Are they monogamous? Do they have multiple partners? Do they have multiple partners at one time? Do they use any type of contraception or do they use any protection against STDs? Have they had an STI in the past? Are they having any issues with sexual function? So like dryness, those types of things. Is it difficult for them to have intercourse? Is it painful? Those are things that we really want to know because it gives us a lot of information to add to our toolbox when we're trying to best help them. But it also can give us other clues on what other tests we might need to consider later on down the road. We also are concerned about their gynecologic history. Have they had any other gynecologic diagnoses in their past? Do they have PCOS, polycystic ovarian syndrome, endometriosis? Have they had a pap smear in the past? And if they have they had any abnormal test results? All of those things are really important to make sure to cover in order to figure out what it is that we need to do. So if I know that they have PCOS or endometriosis already, then I may start at a different place than I would if I'm just starting from the very beginning and I don't know what it is that they have. All right, so we're going to jump back into Slido and I want you to tell me one more thing. Why do we care about our patient's sexual history? Are we just curious? Why do we care about their sexual history? Is there a reason why we want to know what that is? Why do we care about their sexual history? You can let me know in the chat. You can let me know in Slido, whichever one is more convenient for you. Totally fine. Why do we care about their sexual history? Is there a particular reason? Yeah, they could be at risk for other diseases. So if they are, maybe they're abstinent, then we know that that wouldn't be an issue. But if they are engaging in intercourse with multiple partners at one time, or they've had multiple partners without being tested, that might be a reason for them to be tested. You got it. What other reasons? It could also spread to other areas. So if they have an IUD and they have a STI, that could cause other problems. And it gives us a better treatment plan. You're right. So if we know what it is that we need to do, so sometimes if you are working in a clinic where you see male and female patients, sometimes the male will come in and say, "Hey, my partner tested positive," or vice versa. You have a female coming in saying, "Hey, my partner tested positive. I need to be treated." And so when we know that their partner has tested positive, we can go ahead and get what they need. Get them treated is the big concern there. Excellent job. Nice work. All right. So when it comes to symptoms, it's really important that we understand what goes where. So we want to ask them, are they having any urinary concerns? Now, this is more important when we have a client that's coming in saying, "Hey, I think I might have a UTI." Okay. Give me more information. Kind of tell me what it is that's going on. Frequency, urgency. Sometimes that can go along with pregnancy. Other times it can go along with a UTI. So we definitely want to make sure that we understand what their main concern is. But if they are somebody that we're seeing quite frequently, the other thing we want to ask is, "Hey, do you get these quite often?" So when I was in practice, the women's health nurse practitioner that I learned from, sometimes we had clients that came in and they got a UTI just about anytime they had intercourse. And so she would kind of give them a standing order for macrobid or something like that. But it is really important that we do a good deep dive and see what's going on. Other things we want to know, are there any genetic dispositions, any familial history that they have going on? Breast, ovarian cancers, PCOS. So we a lot of times we see that kind of passed down. If someone has PCOS, we start to wonder, will their children have it or does their mom have it? Also, any early menopause. So, a lot of times when women come in and they're closer to menopause and they're starting to complain of those symptoms, I might ask them, "Hey, do you know when your mom went through menopause?" Because that kind of gives us an idea of what it is that's going on and what could be coming down the line for them. Other things we want to know is their lifestyle and social factors. Do they smoke? Do they drink? If so, how often? How many packs per day? How many packs per week? Do they use any other drugs? Now, this is really difficult because some patients, they have to get to know you and make sure that you're not going to judge them before they start telling you all of their dirty little secrets, right? Are they exercising? If they're exercising, how much are they exercising? How often are they exercising? That type of thing. And then what type of nutrition? Are they getting a balanced diet? Or are they mostly eating like me in the middle of finals where it's Snickers bars all the time? And then hygiene practices. What does that look like? Are they douching? Those are important questions to ask. And then we want to make sure that we're documenting their current medications. So these are things like any hormonal therapies that they might be taking or antibiotics that possibly we did not prescribe. We also want to know, do they have any allergies? And if they have allergies, what happens when they're exposed to that type of medication? Are they taking any contraceptives? Do they use protection when they are engaged in intercourse? And if they have had these issues before, what have they been treated with in the past? We want to know, what medications and supplements are they taking, because sometimes those can cause other issues and we may need to know that so that when we prescribe that we can avoid other interactions. Also, those lifestyle behaviors gives a great opportunity for teaching later on down the road. So when we're during this first interaction with our patients, we want to make sure that we establish that comfortable, non-judgmental environment. A lot of times in the clinic, I might even have them just wait to change out of their clothes. A lot of times when you're in that paper gown, you're kind of putting yourself together and you're trying, to hide everything. But we want them to feel comfortable, to be able to share without fear of being exposed unnecessarily. So sometimes I'll just have them wait to change until we're ready for that part of their exam. We want to use inclusive language, building trust, showing that we respect them and their confidentiality. A lot of times this will come into play when you have adolescents in the clinic. And so each state has a little bit different of laws there. So we want to make sure that we are up to date on those. We also want to be mindful of trauma or partner violence. And so I've been reading quite a bit about this and how different clinics do this. But a lot of times when you come into an OBGYN clinic, most of the time we have women go to the bathroom, right, and leave us a sample. So when that's the case, I've seen a lot of clinics that they will have everybody put their name on their cup, right? Because we have to know whose is whose. And they will say, if you are a victim of domestic violence or sex trafficking, please put your name in red. Everyone else use the black marker. So that's just a really good way to kind of do that pre-screening to make sure that we're not missing something that can be really scary. So the next thing we're going to talk about is different complaints and screening. So we know that there are a lot of different ways that we can decrease the likelihood of really bad outcomes, right? And one of those is our screening. So we're going to go through and talk about some of the most common complaints that we see as far as the GU system is concerned and what they could possibly mean. So generally when someone comes in, like I said before, it's usually a complaint. Unless they're just there for a well-woman visit, usually there's something going on. And it can be contribute or attributed to a lot of different diagnoses. So we need to make sure that we're aware of those differential diagnoses that are going with these common complaints. So the first one we're going to talk about is abnormal vaginal bleeding. Now, this can be because a lot of different things. We could see that they have an infection. And so because of the infection, the cervix is inflamed and they're having some bleeding there. It could be because of fibroids or endometrial hyperplasia. So in that case, we want to consider an endometrial biopsy to make sure we're not dealing with some type of cancer or malignancy. Sometimes it's just a change in hormones or stress, things like that. But it is important that we make sure that we cover all of our bases. Now, dysmenorrhea is super common. We hear a lot of women coming in complaining of painful periods from the earliest to right before menopause. A lot of times women will come in saying, hey, my periods are really painful. What can you do to help me? And so we want to get down to the bottom of it. A lot of times we are just really tempted to just push some medication at them. Here, this will fix your symptoms. Go home. You're good to go. But why is it happening? What is happening that we can help them with? Is it endometriosis? Do they have adenomyosis? Things like that. Now, the other thing when we talk about these is it's important that we make sure we understand when we need to refer. Some of these are outside of our scope, outside of what we're able to help with. So we need to make sure we understand that. Now, vaginal discharge. Most of the time, this is coming with some type of an infection, an STI, BV, bacterial vaginosis, trichomonas, and some of these will present very similarly. So it's important that we know kind of what can go where. Generally, if we have somebody coming in that says, hey, I have a discharge and it smells bad, I think I'm either dealing with trick or I'm dealing with BV. So kind of thinking through those while I'm in my office, going through their health history. Dyspareunia. So this is painful intercourse. This could be due to PID, pelvic inflammatory disease. It could also be due to menopause. So somebody let me know in the chat, how do you think this could be attributed to menopause? Sorry, thank you. Yes, you're right. So it's important that we understand it could be due to atrophic tissue. Just that thinning out of the vaginal tissue and friction can cause some pain there. It could also be just some other type of infection going on. So if someone has a yeast infection, that's generally not very comfortable for anything. Other really common ones we see are urinary incontinence. And in that case, I want to know, okay, when does it occur? Is it more like I gotta go and I gotta go right now, or I'm going to pee my pants? Or is it as you get closer to the toilet, you are losing control? Those are important things to ask. Hematuria. Most commonly, we see this with UTIs, kidney stones. If they have no other signs or symptoms of a UTI, like frequency, urgency, things like that, I'm starting to think there's some type of a cancer involved there. And then chronic pelvic pain. Chronic pelvic pain is so common, and it can be due to just a lot of different things. The most common one that I have dealt with was endometriosis. And that's when we have that uterine tissue that is outside of the uterus. So we have uterine tissue that I've even known a patient that had it up in their lungs. It's very, very crazy. Typically, their periods are very painful, and sometimes it can be all the time. Other things is pelvic adhesion. So women who have had multiple abdominal surgeries, they can develop this scar tissue and that can cause chronic pelvic pain as well. So we want to make sure that we're doing a really good thorough assessment, figuring out, okay, what could it be? So knowing those differentials is really important. And then also asking good questions is going to help us as well. All right, we're going to jump back into Slido and answer a question together. Whoops. There we go. All right, so we have a 24-year-old patient who presents to the clinic today with complaints of dysmenorrhea. Which of the following would most likely include this as a symptom? Is it endometriosis? Is it bacterial vaginosis? Is it stress incontinence or trichomoniasis? What do you think is most likely to include this pain, um, painful periods as a symptom? What do you think? All right, let's see how we did here. There we go. All right, 100% of you said endometriosis, and you're absolutely right. So, endometriosis, a lot of times, is going to have those painful periods. So, it's really important, again, that when we're thinking about these things, we start to think about what it could involve, because then that's going to help us kind of head down a certain trail, or it's going to help us know what type of recommendations we need to make. And so, with that in mind, let's start talking about what our recommendations are for screening. So, for pap smears, it's important that we understand who needs what and when they need it. So, as far as guidelines go, if they're 21 to 29, it's okay for them to get a pap smear every 3 years before we retest. Now, if for some reason one of those was abnormal, that might change things. But generally, they only need a pap smear every 3 years. Now, it's important to understand that a lot of times insurances will cover a pap smear once a year. And so there are women that come into the clinic all the time and say, hey, my insurance covers a pap smear. I would like to have that done. Other times I explain and I give women the option. Hey, if you're here for a well woman exam and you're not having any pelvic complaints, you don't need a pap smear today. You don't have to have a pelvic exam. But if you'd like one, I'd be happy to do that for you. If they're from 30 to 65, we're going to do an HPV test only if, um, only. So we only need to do an HPV test. And it's okay to wait 5 years before we do that again. Or we could do an HPV and a pap test. We call that co-testing. And that's normal to wait every 5 years. So they don't need one for another 5 years as long as it's normal. Or we could just do a pap smear. And again, we're going to wait 3 years before we retest for that. So depending on where they're at, what they need, what the results come back as, that's going to determine the following steps. Now, if they're older than 65, they don't need a screening if they've had at least 3 normal or what we consider negative pap smears, or they've had 2 normal or negative HPV tests in the last 10 years, and they don't have any history of precancerous cells on their cervix, or they've had their cervix removed as a part of a procedure that did not involve a cancerous diagnosis. So, depending on their reason for surgery, they might never need a pap smear again. Now, it used to be there was a standard of just doing a vaginal scraping to make sure that there wasn't anything there. But as far as recommendations, these are the current ones. Now, we also know that we have other reasons why we might need to do some screening. Now, the most common that we see are pap smears, mammograms, um, osteoporosis, and STI screenings. Also, urinary incontinence, depending on their concerns. So when it comes to cervical cancer, we just discussed those previously. When it comes to breast cancer, generally we're going to recommend a mammogram starting between ages 40 and 50. And it's going to depend on their risk factors. Now, if for some reason they had a first degree relative that was diagnosed, let's say at 40 years old, then we're going to recommend this patient be screened 5 years prior to that. So when I first started working in the clinic, we had a patient that came in and she had a first degree relative. I don't remember who it was, but had been diagnosed at the age of 30. So she should have been starting screenings at age 25. And at that point, she was breastfeeding. And so they were going to have to do an MRI. And she's like, I'll just wait. It's not a big deal. But we also have genetic testing now that kind of gives us more information, especially if you're having that first degree relative, mom, sister, things like that. STI screenings are really important that we talk about the need for these and help our patients figure out if they feel like they should be screened. So typically I tell women get screened once a year if you know, generally unless you are in a monogamous relationship where there is no concern, um, get screened once a year. If you happen to have multiple partners within that year, then I recommend getting screened with each partner just to make sure that, your body is healthy. Because when you have intercourse with someone else, they're giving you their side of things, and you don't always know if that is truth or not. So typically, I recommend, especially our younger patients, to get screened yearly if they're less than 25. Then if they're having any urinary incontinence issues, we'll recommend that type of screening. So we send them for a pelvic floor assessment. We get them to do a bladder diary. So what's happening? When are you getting up? Did you make it to the bathroom? Are you having to wear a incontinence pad daily? Things like that. And then we can send them for urodynamic testing where they insert little catheters, little meters that tell us, sphincter tone, that type of thing. And then for our older women, we have what's called a DEXA scan, and that's looking for osteoporosis. Typically, we're going to recommend starting this at age 65, but if they have other risk factors that would increase their risk of osteoporosis, then we can start that earlier for sure. Okay, so we've been through the different screenings. Now we're going to move on to more of those deep down common GU disorders that we see in the clinic. And the first one that I see very, very frequently are UTIs. Now, typically, these are bacterial and they wreak havoc. So a lot of these result from E. coli is very common pathogen that we see here. And what it does is it causes inflammation. And so we're going to see some key symptoms here: dysuria, increased frequency, increased urgency, and sometimes suprapubic pain. So a lot of times women will come in and they'll say, hey, it really burns when I pee. I'm going a lot more frequently, and I'm starting to have some like lower pelvic pain. And that usually gives me the key that, hey, they probably have a UTI going on. Now, if they only have a couple of those, then we might think about other things. Like if they're having increased urgency and frequency, then I might start to think if you're within childbearing years, potentially pregnant. So it's really important that we're doing a really good assessment in those situations. Another one that I found very commonly, especially in women coming in for infertility consults, is we would find polycystic ovarian syndrome. Now, this is where we have increased androgen production, and that causes a lot of things: irregular periods, hirsutism. So, a lot of times you'll see facial hair, acne, and a lot of times we see infertility. Now, the reason is most of the time, PCOS patients, they're not ovulating or they ovulate inconsistently. And so getting pregnant can be very difficult if you're not ovulating. There's no egg there. Even if there is sperm present, conception can't occur without one or without both of them being there. So increased androgen production, we see ovulation, also insulin resistance. And so generally what we'll do is we have women that are having irregular periods, or maybe they haven't had a period for a while. I once had someone that came in and said, it's been 150 days since I've had a period. Um, that lets me know, hey, something's going on here. First, I want to make sure that she's not pregnant. And then I'll probably send her for a pelvic ultrasound once I get a good history. Because typically we're going to find some other things. You know, you start to see that hair under the chin, acne, things like that. And so this over here on the left side of your screen is a normal ovary. We have a couple follicles there. And then you see them kind of developing into mature follicles that are able to be released. With polycystic ovarian syndrome, you're going to see what we call the string of pearls effect. And so you're going to see a lot of these cystic like follicles. And a lot of times the ovary can just be covered in them. So it's important that we make sure that we get that testing to figure out what it is that's going on. Now, like we talked about before, endometriosis is another common one that we see. And this is where we have that ovarian tissue, that endometrial tissue that's growing outside of where it should be. And so a lot of times with this, chronic inflammation. So they're just, if they're not in pain all the time, then generally they're having pain, chronic, awful pain with their periods. I know a friend of mine that has endometriosis, and she said it's to the point where she can't even cuddle with her kids during her period because everything is just so inflamed. She's so uncomfortable. It is so painful. And so they will have things like adhesions from this. I've even seen women that have had this up in their lungs, and that can cause some pretty damaging side effects as well. So think about all the inflammation that's going on. A lot of times these women will have issues becoming pregnant. And so that is a lot of times why they present as well. If they've just been, maybe they started off with painful periods. And so someone put them on a birth control pill, but didn't do the deep dive into figuring out what it was that's going on. Then they go off their pill. They're like, okay, I'm back to my painful periods, but I'm not getting pregnant. And so a lot of times this is what we find. Now, PID is one of those more serious things that we find. This is an infection that we see that can lead up to inflammation in the fallopian tubes, and it is caused by either gonorrhea or chlamydia, typically. And so basically what happens is it's not taken care of. So if someone's not getting screened, they have PID or they have gonorrhea or gonorrhea or chlamydia and they don't know it, it can lead to a pretty bad inflammation. And so they may have just start with some lower abdominal pain and they can get really, really sick. But the telltale sign here is when I do that pelvic exam and I insert my fingers and start to move the cervix around, a lot of times these women are crawling up the table. It hurts so much. And so that's a telltale sign that they have some PID going on. And we can talk in a later lecture what that type of treatment would look like. So later on, a lot of women will show up with difficulties in a lot of different areas. One of those areas is hot flashes, night sweats, even painful intercourse because of that vaginal atrophy. So that estrogen goes down. Our vaginal tissue needs that in order to provide adequate lubrication and things like that. So if they don't have that estrogen, then a lot of times that friction can cause some pain or some discomfort there. And so a lot of times they'll show up with vaginal dryness. They even have urge incontinence because of that decrease in estrogen there. So when it comes to getting that history, we know we need to start. We know we need to just do that thorough assessment guided by what our patient's history says. So we're going to choose those appropriate diagnostics. We're going to formulate that individualized care plan. We want to make sure that we understand and remember that not every patient is the same and each one's going to need a little bit something different. So maybe if they're having pelvic pain, we will go ahead and do a pelvic exam, obviously with their consent. And then we're going to individualize based on what that particular patient needs. We're going to educate them on those preventative health and lifestyle changes. It is so important when we're helping them to live a healthy lifestyle. And when we're going to facilitate those referrals, we want to make sure that if it's above something that we can do, we get them where they need to be. And remember, we are collaborating. Everything doesn't have to be our specialty. We don't know how we don't have to know how to do everything. We just want to make sure that we get our patient the care that they need from the person that they need it from. All right, let's jump back into Slido. I have another question for you. I want you to tell me which of the following are signs or symptoms is most applicable to pelvic inflammatory disease. Is that dyspareunia, atrophic vaginal tissue, cervical motion tenderness, or yellow discharge with a fishy odor? What do you think? Which of these is most applicable to PID? Which one would we most likely see that my ears are going to raise up and I'm going to go, uh-oh, I think they have PID going on? Which one would it be? Give me a couple seconds here. All right, let's see how we did. I have a feeling you guys did great on this one. 100% of you said that cervical motion tenderness. You got it. So a lot of times when I start moving that cervix around, they're crawling up the table and my spidey senses go off. So if you're new to Archer Review, or even if you've been around for a while, I'd like to tell you a little bit about our what we have to offer as far as the FNP program. So we have lots of different options. We have our question bank with over 1,600 questions. We have a readiness predictor. We have 16 hours of content. You can get our on-demand videos. They kind of go in depth as to what it is that's going on, kind of explain it a little bit more. And then we have our SurePass combo. This is by far my very favorite product to recommend because it has everything you need. It's going to have the Q bank, the videos, and then also includes our live review. So we also have a pass guarantee. So we will continue to work with you if you need help passing those boards. So go ahead, scan that QR code there on your screen. Go check out what students are saying about this. Y'all, I wish this was around when I was in APRN school. This would have been a life changer. So come join us, see what all the hype's about. And we can't wait to walk with you as you pursue your degree as an advanced practice nurse. All right, so we're going to move and change direction a little bit, and we're going to start talking about how do we actually do that physical assessment. So when we're doing a physical assessment, especially when it comes to the GU, we need to understand, what all is in that area, right? So the female anatomy is quite complex. So we have the vulva. So that is kind of that whole external area that we have. We have that mons pubis. I like to think about it mons mound. So we have that kind of fatty tissue over that pubic bone. We have the labia majora, so those thicker outer lips. The labia minora, so inside that, thinner, more shiny. The clitoris is at the very top here. So the clitoris has that erectile tissue. Its basic function is there for sexual stimulation. That's its job. We have the vestibule, so that's that area in between the labia minora, and it contains the urethral opening and the vaginal openings. And then on the sides down here, we have the Bartholin's and the Skene's glands. They're responsible for lubrication. And then we have the perineum. So the perineum is that area in between the vaginal opening and the anus. So now that we understand where everything is, what are we going to see here? Now, typically, Skin color should be just smooth and it should be the general color of our client. We know not everyone is pasty white, not everyone is dark, dark, dark. A lot of times they're somewhere in the middle. And so if we're finding things that maybe they have hyperpigmentation or they have ulcerations, regardless of where it is, that is not normal. And we need to use that information moving forward to get them taken care of. Maybe that means a biopsy or a culture. When it comes to the labia, generally they should be symmetrical, but remember, every client is different. So some asymmetry may be normal, but if it is completely different, that is a reason for further investigation. When it comes to the clitoris, so this should generally be non-tender. Some women have this pierced, but depending on what it is that's going on, they might have some hypertrophy. They might have some adhesions there. It may be completely removed depending on their cultural background, The urethral opening should just be there. We shouldn't see really anything exciting. We shouldn't see anything coming out of it, whether it's discharge or a prolapse. We shouldn't see anything coming out of that area. As far as the vaginal opening, we shouldn't see any discharge, any ulcerations, any bruising. And then the perineum should just be smooth. Now, sometimes, depending on a woman's delivery situation, delivery history, she may have a scar from a laceration or an episiotomy that may have occurred. And sometimes we will see some fistulas there. When I first started practicing, I had a woman that came in telling me she was having stool coming out of her vagina. And sure enough, we did an exam and found that there was indeed a fistula. So we're going to start with trying to figure out, okay, so our client comes in, they're having some issues. How do we move forward? So what do I need to do in order to figure out what is happening? So the first thing that we do is we're going to prepare our patient. We want to make sure that they have the privacy that they need. We're going to give them some drapes. A lot of times, depending on the clinic that you're in, you may have a like a cotton gown. You may just have those paper gowns that rip really easily. But whatever it is, we want to make sure that we do provide them a drape, make sure the room is closed. Now, typically, if you're having a door that opens, typically it's going to open in and not out, and it's going to be behind the patient. So that if somebody does walk in on accident, they're not getting a full view of what's going on. The other thing we want to make sure is explain what we're doing before we do it. We want to tell them, hey, well, I'm going to start from here. I'm going to work my way here. I'm going to do this, this, and this, and then make sure that we get consent before moving forward. It's also important that we make sure our client knows at any point if they are uncomfortable, if something is hurting them, all they have to do is say stop and we will abide by those directions. Now, the next thing is we want to get them into a good position. Most commonly, we're going to use lithotomy, but a lot of times I will use a frog leg position. So just have my client scooch down to the end of the table. I'll move the table out so that they have that footrest, and then they can just kind of frog leg. It's a little more comfortable and a little more controlling for them. They don't feel as vulnerable. And remind them, hey, this is your exam. You are in control here. I will respect your boundaries. So if something is hurting or they're just uncomfortable, all they have to tell me is stop and I will abide by that. Okay, so how do you make your patients feel most comfortable? I'm intrigued. How is it that you make your patients feel the most comfortable? We are almost done here. You guys have been amazing. Thank you for sticking with me. How do you make your patients feel the most comfortable? You can let me know in the chat. You can let me know in Slido, whichever one works for you. So a lot of times I like to sit. So when I go in, a lot of providers will stand and they'll kind of pace. No, I like to go in. I like to sit. I want to be kind of at eye level or maybe just a little bit lower than they are. So communicating well, letting them know what's going to happen. Absolutely. Warming that speculum. Yes. So whether your speculum, so a lot of times when I would grab my speculum, it would come out. Oh, you probably can't. There we go. When I would grab my speculum, it would come out of a warmed drawer. And so I didn't have to warm it up, but you can run it under some warm water. Excellent. Tell them what I'm doing before I do them. I'm not going to do anything that they're uncomfortable with. Yes, letting them know, developing that rapport is really important. And explaining the procedure. Yeah, let them know what you're doing and why you're doing it. So important for their comfort. Excellent. I love it. So after we have gotten them comfortable and explained everything, we're going to start with inspection. We're just going to use our eyes. We're looking at that skin integrity. We're looking for redness, rashes, maybe ulcerations that might be there. We're looking, is everything symmetrical on both sides? Is there a discharge? Is there an odor that could lead us to think there might be some type of infection? And then we want to make sure that we're noting the condition of each anatomical landmark. So is there anything, any issues with the labia, any issues with the clitoris, any issues with the vaginal opening? And then once we have done a visual with our eyes, the next thing we're going to move into is palpation. Now, palpation allows us to assess those deeper structures. And so we are going to, with a gloved, clean hand, we are going to gently palpate the labia and the vestibule. We're going to palpate those Bartholin's and Skene's glands. We're looking for tenderness, any swelling. Now, this is a really common place for women to come in with a cyst, especially if they're having vaginal pain. They may not know what's going on there. I had a woman that came in, she had a Bartholin's gland that was quite infected. And so generally when you touch that, it's not comfortable. So we want to be very, very careful there and very mindful of what we're doing. We also want to check for masses in the perineum area, any fistulas or scarring. This is really important for our postpartum or our post-surgical clients. Is there scarring? Is there stitches still in place? Is there any discharge or anything from that situation? Now, the next thing we move into is that speculum examination. Okay, so if we need to do a speculum examination, maybe we need to do a pap smear, or maybe we are just doing an internal exam. I want you to get a warmed speculum and you're going to lightly lubricate it. Now, typically what I would do is I would just lubricate the underside because that's kind of what's sliding in. And what I will do is I will take my non-dominant hand. So typically I use my left. I will kind of make a V with my fingers to kind of steady and put my hand on our client. And I'll let them know, hey, you're going to feel my hand. You're going to feel my touch, and the next thing you're going to feel is the speculum. And so I'll insert the speculum sideways through that area into the vagina. And then once it's in, I will insert it, turn it the right way. And then I'm going to go ahead and open just far enough to where I can see. Now on the back of the speculum, depending on what type you use, a lot of people use plastic or metal. There's this little lever there, and then you can lock it in place by using this nut and bolt situation. And this is just going to let me assess, what does the cervix look like? Is there anything in there that I need to be concerned about? Any type of discharge that I need to culture, a prolapse. We want to always make sure that when we're using that lubricated speculum that we're proceeding slowly and watching our client. Are they kind of like uncomfortable? Are like they groaning, like something's painful? And then we want to make sure that we document those internal findings. Now, the last thing we do after our exam is we want to document. We all know that if it isn't documented, it didn't happen, right? Our charting has to be accurate and objective. We need to include size, color, location, and any consistency of abnormal findings as appropriate. And then we want to make sure that we're using the right anatomical terms. So using that the medical terminology, but when we're explaining it to our client, we want to make sure we use lay terms that they're going to understand. Now, if there happens to be a situation of sexual assault, we want to make sure that we include photographs, but make sure that we get our client's consent first. Now, afterwards, we want to make sure that we educate them on what it was that we found, and we want to use it, explain that in a way that they're going to understand. Because if I start using distal and proximal and labia minora, they may not understand that. So I want to make sure that I maybe draw them a picture and show them where my finding was located. Talk about how they can prevent STIs, how they can monitor for things that are not supposed to be there. If we do find abnormalities, we want to talk about what's the next step. Who do we need to refer to? And how long might it take to get there? What steps have we done to get them there? The other thing I like to do is send them home with some written information as well. Now, the most common things that we see when it comes to the genitalia are infections. So things like vaginitis. A lot of times we will have women that come in and say, "Hey, I have an ulceration there," or "I have a bump." And so that's really common. Inflammation, whether they have been in contact with something that wasn't appropriate. I did have a woman once that went camping and she accidentally wiped with a poison ivy leaf. That was awful. They can have those masses, like we talked about with Bartholin's glands. Those can get infected and cause some really painful everything from walking to sitting. It's not fun at all. And then we also have other congenital abnormalities. So imperforate hymen, labial fusion, or maybe they've had scarring from genital mutilation or they've had other assault injuries. So it's important that we kind of keep in mind everyone is a bit different and we want to meet them where they are. And again, we're going to make sure that we're documenting well. We are educating them about what we found, what that means, what are those next steps, and then tell them who we are referring them to and about how long it would take for them to hear from them. Now, a lot of times when they leave the clinic, let's say I'm sending them to a breast specialist, I'll send them with their card and I'll say, "Hey, I'm referring you to Dr. Mondros's office. You should hear from them within 3 to 5 business days. If you don't, please give them a call." So they kind of know who they're going to be seeing and how to get a hold of them just in case. Now, as APRNs, our role is not just to diagnose, but we want to make sure that we're educating and we're providing preventative information, right? We want to do that thorough genital exam. We want to help detect those early signs of disease. We want to build trust with our patient. We want them to know that they are able to share information with us and we're going to meet them where they are. We are a big and vital role in educating and preventing. And we want to make sure that our clients have the care and the information that they need in order to do just that. All right, so we have made it to the very end. I have one last question for you. How do you feel about the GU system? How do you feel about the GU system? You can let me know in the chat. We've been through a lot of information here. We've been through assessments, we've been through education, we've been through screenings. I'm hoping that you are feeling more confident in this area of studies. Feeling pretty good, Christina. Awesome. So remember, here at Archer Review, we're more than just test prep. We're here to walk alongside you. We're here to help you in whatever phase of the process you're in. So don't forget, go ahead, check out that SurePass combo, see what the hype is all about. And remember, if you have questions, if you have concerns, please send us an email to nursepractitioner@archerreview.com. Those come directly to us. They are answered by real nurse practitioners, and we are always delighted to help you in any way we can. Thank you guys so much for joining me. It's been an absolute delight having you, and we hope to see you at our next webinar. So thanks for joining us. Thanks for being a part of the Archer Review family.